Welcome to the second lecture for Unit 1 in Transitioning to Value-Based Care MOOC from the College of St. Scholastica. In this lecture, we're going to define value-based care more fully than in the first lecture, including discussing the shifting of financial risk associated with transitioning from fee-for-service to value-based care. We will also identify and define terminology associated with value-based care so that we can proceed through the remaining lectures with at least a common meaning to the terms we're using. Many, if not all of you, are likely to be familiar with the terms included in this lecture, but we do find that lack of quote-unquote semantic interoperability, that is, ensuring common meaning and data sharing, is a very widespread issue. Even commonly used terms are often interpreted differently. As an example, the term healthcare provider is fairly commonly interpreted to mean only physicians and other persons, such as nurse practitioners, physician assistants, etc., who can bill for healthcare services. Others interpret the term provider to refer to both such persons as well as organizations such as hospitals, nursing homes, home health agencies, pharmacies, and other entities. So we'll discuss this and other such further in this lecture. So let's do some level setting on the concept of semantic interoperability first. Semantic interoperability is extremely important in general, and especially in a course where there are many new terms or terms that need to be more precisely defined in their use. We will devote an entire lecture to interoperability in all its forms later, but discussing semantic interoperability here helps us assure common meaning as we proceed through this MOOC. Semantics refers to the study of the meanings of words and phrases in language, or in the meanings of words and phrases in a particular context. Students of interoperability may recognize that different meanings within different contexts is actually risky, but unfortunately unavoidable. Semantic interoperability, as defined by HIMSS, is the ability to exchange information and to use the information that has been exchanged. In other words, merely passing data from one computer to another does not assure that the data will be able to be used as intended. We discussed how the term provider may be interpreted differently by different people as I opened this lecture. In the next couple of slides, we will also discuss the difference between health plan and payer. If either of these sets of terms are used synonymously, communications could be delayed or even lost. Semantic interoperability, then, is generally achieved through strict adherence to terminology standards where they exist, or is agreed to by contract or other form of agreement between parties exchanging information. In this MOOC, we will seek to use terms as defined by standards, such as those adopted by the federal government or an American National Standards Institute or ANSI accredited standards development organization. Examples of these standards include ICD-10-CM for diagnoses and procedures, SNOMED-CT for problem lists and other uses, and even such simple standards as zip codes for addresses. In the absence of there being a formal standard terminology for a term we want to ensure is understandable in the context of value-based care, we will seek to use terms defined by one or more recognized authorities, such as CMS, or as most commonly defined in the literature. Some terms generally are new terms or terms used in new ways in the context of value-based care. Also note that by common convention, we will always spell out an abbreviation the first time it is used in a lecture, but not in subsequent lectures. However, all terms will be spelled out the first time they're used in any given assessment quiz. The vignette on this slide is used to emphasize the importance of semantic interoperability in value-based care. The vignette is a provider and a health plan failing to effectively exchange information with each other came to realize the problem was not in technology, but that their business policies were different enough that the data they considered essential were captured using different vocabularies or they had different definitions of essential data. Although the example here is quite generic, a similar recent conversation that I had with a health plan provides a more specific example. The health plan representative commented to me that when a claim was received with a code for a mammogram procedure, the health plan could not determine if the procedure was actually performed, was recommended to be performed, or had been performed by another provider. The health plan representative further commented that because they could not locate the results of the mammogram, they concluded that there are no standards for coding. Yet you and I know that providers do follow standards and guidelines for coding diagnoses and procedures. According to such, documenting a procedure code on a claim means the procedure was performed by the provider during the period of time covered by the claim. No further evidence of the study having been performed should be necessary unless fraud and abuse is suspected. Health plans have arrangements with some commercial labs for being supplied results of diagnostic studies, but this is not the case for diagnostic studies performed by most hospitals or providers other than commercial labs. This is not to say that all providers always code correctly, but this example certainly would be a rare error and an unlikely way to commit fraud. And yet, obviously, we are in an issue of semantic interoperability in both vignettes. Before we get more deeply into value-based care, some more definitional level setting is appropriate. As noted in the introduction to this lecture, the term provider is not always defined the same by everyone. A quick search of the internet identifies a variety of interpretations. There are even differences in different sections of the Code of Federal Regulations. For example, the Family and Medical Leave Act of 1993 in its regulations defines healthcare provider as a doctor of medicine or osteopathy who is authorized to practice medicine or surgery as appropriate by the state in which the doctor practices or in any other person determined by the Secretary of the U.S. Department of Health and Human Services to be capable of providing healthcare services. The Health Insurance Portability and Accountability Act, HIPAA, of 1996 does not define healthcare provider, but in the Administrative Simplification section, where transactions code sets privacy and security standards are specified, HIPAA defines covered entity to include providers who transmit any information in electronic form in connection with a transaction referred to within subsequent sections of the law. Regulations issued pursuant to HIPAA identify the term healthcare provider as having the meaning as defined in the Social Security Act, which is provider of medical or health services, and any other person or organization who furnishes, bills, or is paid for health care in the normal course of business. The CMS glossary also provides a definition of Medicare provider that is consistent with this definition. And so this is the definition we will use in this MOOC, encompassing both person and organization. The term health plan is another semantic issue for us. It is fairly consistently used in the context of government work, with the definition provided in the HIPAA regulations as an individual or group plan that provides or pays the cost of medical care as defined in the Public Health Service Act. Despite the common definition of the term health plan, the term payer is often used synonymously with health plan by many providers and even health plans themselves. The term payer, however, has a distinct meaning of its own. The Workgroup on Electronic Data Interchange, or WEDI, is an advisor to HHS for HIPAA transactions and code sets and distinguishes payer as an intended entity responsible for claims processing functions. A health plan may perform such functions, but may contract for some or all of such services to typically a vendor, then called a payer. When a health plan performs such functions, however, its primary purpose remains as the one paying the cost of medical care and should be referred to as a health plan.